Hello, everyone. My name is Laure Gossec. I'm a rheumatologist working in Paris, France, and very happy to be with you today to discuss very early psoriatic arthritis, and specifically, how can we identify patients who are at risk of developing PsA, and why is this important? So with PsA, we really have a perfect model for a preclinical disease state. And for psoriatic arthritis, this preclinical state is skin psoriasis, since we know that around 1/3 of patients will develop PsA when they have skin PsO. And this makes it a wonderful pathophysiological model to analyze very early disease or even pre-disease states. How can we identify patients with PsO who will develop PsA? Well, there are some elements on which everyone agrees, and these include obesity, involvement of the nails, as well as family history of PsA. And then there's a bit less agreement on some other elements, some genetic predictors, as well as the extent of skin psoriasis or some specific locations for skin psoriasis might be at higher risk of PsA, but this is not very clear. So among these, only one is modifiable, and that is obesity, which is why we really have to discuss this with our patients who have skin psoriasis, that they have to do something about their obesity, or we have to do something if we want to avoid some cases of PsA. So this brings us to the very interesting concept of how to treat pre-PsA, that is, can we intercept disease and modify natural disease history by treating patients when they have skin PsO and they are at risk of developing PsA? We can use the criteria developed by EULAR for clinical trials in this population. And is that worthwhile? Well, we don't really have a full response yet because there is one randomized clinical trial which is ongoing, which is called PAMPA, but we don't have the results yet. But from registries and cohorts, what we can say is that by treating with biologics, it looks like we lower the risk of developing PsA by around 80%, and that using drugs which target biological drugs which target other elements than TNF, more specifically IL-23 inhibitors or IL-17 inhibitors, appears to be efficacious to avoid the appearance of PsA. Now, again, this is not randomized controlled trial data, so we have to wait for more data, and also the data from different sources is slightly conflicting, but it looks like we might be able to avoid the appearance of PsA in some patients. Now you might wonder, is it worthwhile to treat early? Well, this idea of very early treatment may be of a window of opportunity, which is often put together with a treat-to-target approach. I have to say we don't have as much data in PsA as we do, for example, in rheumatoid arthritis. But there are some studies which have indicated that by treating early, you can potentially improve the prognosis for the patients, of course, in terms of symptoms, of pain, of quality of life, but also of avoiding progression to polyarticular disease. And we know that polyarticular disease is in itself predictive of structural damage, and also to avoid structural damage and long-term handicap and functional disability. What about how we can treat patients with very early PsA? Now they already have PsA, and how should we be treating them? Firstly, let's look at the recommendations. The drugs that we are allowed to use for fully developed PsA can all also be used in very early disease. This means both conventional synthetic DMARDs, such as methotrexate or leflunomide, also targeted synthetic DMARDs, such as JAK inhibitors or apremilast, and finally biologics, such as TNF inhibitors, IL-17 inhibitors, IL-23 inhibitors. All of these drugs can be used in very early disease. Now, for patients with very early disease, but also more specifically oligoarticular disease, which is very often a form in early disease, it might make sense to hit a bit less strongly on the disease. And in this situation, to use a conventional synthetic DMARD as the first drug would be at least what you, Laure, would recommend. And now we also have a recent trial in very early PsA, which is called Foremost, which showed that treating with apremilast seemed to modify a bit the natural history, and that less patients went into polyarticular disease when they were treated with apremilast rather than with placebo. So those are elements to take in mind. But I think the most important is when we treat patients with early PsA is to try to maximize quality of life and avoid progression of disease and structural damage. And for this, you should use whatever drug you're used to using in PsA, which seems the best adapted for your patients. We don't currently have specific treatment recommendations for patients with very early disease. So, dear colleagues, the treatment of very early PsA and the interception of the progression from PSO to PsA are definitely hot subjects in 2025. Look out for more information at the next congresses.